afternoon. My name is Naya Thornton, and I'm a master's student in the International Studies program at Hamilton Luger School. I currently support the 21st Century Japan Politics and Society Initiative as a student assistant, and I'm a proud member of Alpha Sigma alumni chapter of Sigma Gamma Rho Sorority Incorporated. Imagine with me that you're sitting in a meeting, surrounded by officials who outrank you in age, seniority, and experience. You sit in the back of the room, the sole person wearing pink, amidst the sea of black, gray, and navy suits. Your position allows you to survey the room, watching the men in black who are aware of your presence but have made no moves to warrant your escape. Yet. You count the number of people in the room, and there's about 30. You count the number of women, the number dwindles to about 10. You count the number of those who are black, the number is even lower. You are one of two. For the number of black women, you are one of one. This was my daily experience during my internship in the US Department of State. And while my experience in the Office of Japanese Affairs was a great honor, I would be lying to say that it wasn't at times intimidating being the youngest and, more often than not, the sole woman of color in the office full of the elite. While on the economics team, I had the privilege of learning about US-Japan foreign policy. I had the opportunity to network with colleagues from a number of different backgrounds, and I have made lifelong friendships with other students. But my time at the State Department often included feelings of imposter syndrome. Not just in terms of being the minority among the elite, but because prior to that internship, I had no experience with international relations. I was a liberal arts major, and I had no idea why they picked me of all people. You know what my supervisor told me? Why not you? He said, your resume is astounding. You've studied abroad in Tokyo and did an internship in California. Writing is becoming an increasingly lost art, so your English degree is an asset here at State. You speak Japanese and Spanish. Why not you? So I asked myself the same thing. Why not me? For the spring 2025 cohort, the State Department had 1,900 applicants, and I was of the 210 selected. I sit in a room with the elite because I earned my spot, not because it was given to me. I work with the elite because I am elite. And if anything my academic career has taught me thus far is that I'm much more resilient and capable than I give myself credit for. I have never not succeeded at something I put my heart into, and while at times my path may be clouded with self-doubt, I am unstoppable. I am uniquely me. I am one of one. And as I navigate my remaining journey at HLS, I will continue to embrace each new challenge that arises. I am part of the next generation of elites who assume the roles of officials, policymakers, and diplomats, and it's through these events like ARW that we must continue to instill confidence in the next leaders of global change. One day, you too might find yourself in a meeting surrounded by people who outrank you, but remember the path you took to get there. All roads lead to the same destination eventually, and while it may take you longer than others, you will find yourself exactly where you're meant to be, among the elite. Thank you. It is now my pleasure to introduce our next panel on America's Global Health and Development Strategy, moderated by Professor Sarah Bowerly-Dansman. Thank you.
Thank you so much, Naya, and thank you all for being here this afternoon. As Naya mentioned, my name is Sarah Bowerly-Dansman. I am an associate professor in the International Studies Department here at the Hamilton Luger School, and I'm also the faculty director of the Tobias Center for Innovation and International Development, which is sponsoring this panel today. So I'm sure that many of you know a little bit about the state of affairs when it comes to US policy towards global health. It's been across the headlines that over the last year, the administration has severely cut and disbanded US aid. Earlier this year, the US left the World Health Organization. The administration also cut roughly 80% of pre-existing global health contracts, which totaled a little bit less than $13 billion. In September of last year, the administration unveiled its new approach to global health, calling it the America First Global Health Strategy. The strategy is organized around 3 pillars: making America safer through disease surveillance, stronger through strategic bilateral relationships, and more prosperous by promoting American health products and innovation abroad. A key feature of this strategy is a fundamental shift from a multilateral kind of way of organizing what we do in the global health space to one that is focused on bilateral government-to-government agreements. 9 African countries have signed memoranda of understanding by the end of last year with the administration, and the administration plans to complete many more in the year ahead. These MOUs tend to focus on requiring partner countries to take on commitments towards self-sufficiency and also require partners to commit to provide U.S. access to local resources such as critical minerals in exchange for public health assistance. So this is a very different way of thinking about global health from a strategic perspective, as well from how we're actually implementing global health. And the strategy raises core questions that cut across political and partisan lines. Can a bilateral, interest-driven model deliver the same or even better global health outcomes as the multilateral model that it is replacing? And what are the costs associated with this transition? The early evidence is really mixed. We see that large financial commitments have been announced, but on the ground, there's been severe service disruptions. And so today, this panel is going to address those issues and perhaps just help clear the air and help people in the audience understand what is happening with US global health, because it's oftentimes very hard to know what the administration says a lot of things, and it's sometimes unclear what is actually happening on the ground. And so we're gonna organize our time together in 3 rounds, followed by Q&A, and then followed by last words from the panelists. So as we move through our session today, please be thinking about your questions. We want to get as many of them in as possible. I'm really delighted that we are joined today by 3 really distinguished panelists. I'm not going to spend much time going over their bios because it would take the entire session. But over on my right, on your far left, is Dean Carlin, who's the Frederick Esser Nemers Distinguished Professor of Economics and Finance at Northwestern. He's a founder of Innovations for Poverty Action, and he previously served as USAID's chief economist until February of 2025. In the middle here, we have Shannon Kelman, who is Senior Advisor for the U.S. Liaison Office at UNAIDS, and she was previously Senior Policy Director at Friends of the Global Fight Against AIDS, TB, and Malaria. And we have Sabs Qureshi, who's Vice President of Global Pandemic Prevention for Pax Sapiens, and she has a long career working in WHO, USAID, UNICEF, and many other organizations. So thank you very much to our panelists for being here today. So let's start off talking a little bit about the logic of the strategy. And Dean, I'm going to start with you. So I saw that you wrote on LinkedIn that the Global First, or the America First Global Health Strategy is elegant in its simplicity, but it's like trying to bake cookies with only using chocolate chips, which I thought was a great analogy. So as someone who spent 2 years inside USAID trying to make programs more cost effective, can you talk to us a little bit about what the old model got wrong? Because there are some things that it got wrong, but also sort of what is America First Global Health Strategy trying to solve, and kind of is it going about it the right way?
Sure. Okay, so let me answer it into the 2 parts.
Yes.
What was, at the big picture, what was wrong in the prior model? And to be perfectly clear, I joined USAID in 2022, not because I thought it was an amazingly well-run, making great decisions allocations. Quite the opposite. I saw it as a group that had a lot of internal energy for using evidence to make better decisions about how they were allocating resources and designing programs and evaluating their own programs. but we're bottlenecked in how to actually do that. And so that's the reason I joined, was to help move the needle on how well they design what they are funding. And so it's always been a bit of a weird situation given what's happened, because there's a lot of really good things that were at USAID, but it is, it would be false for me to say, to like defend it like, without any hesitation as if it was some perfectly well-run organization, because then like that's literally why I joined, is to help. But I never would have joined if there wasn't huge energy from within. And there were pockets that were very well functioning and some less. Global health was actually one of the best functioning areas within USAID. Likewise, to be perfectly blunt, it's the area I spent the least time on, because we were cared about our effectiveness as a small and growing office doing this. And so we went to where the biggest pockets are that we thought we could move the needle on, and we shifted about $1.7 billion, but none of that was global health money. That was, it was some nutrition money and some other things related. One of the big things that I think we saw with global health that was that because it didn't operate, and this is actually one of the good things about the new strategy, but then they lack a lot of the details underneath to actually make this work well, is that it did work in parallel to government, more so than it should have. So it wasn't funding government to then improve what government was doing, but setting up parallel health clinics on other matters. I was just on a panel with someone else who spoke very poignantly about examples in her experience in Mozambique, where people would say, I prefer to have HIV than TB and other less serious diseases. Why? Because the health clinics in HIV are better, right? But there's no reason to have parallel systems of that nature, and that was an inefficiency and not paying attention to how to strengthen local government. So that segues exactly to what's wrong with the current system, which is claiming to have that mentality and yet doing absolutely nothing underneath the hood to make that happen. And that's the point of that kind of tongue-in-cheek chocolate chip cookie reference. Is they said, we want to bake cookies and chocolate chip cookies, and so here's the chocolate chips. And so all they're doing is saying they're going to transfer commodities, transfer money to buy commodities, and then somehow magically the countries are supposed to 10 years later have well-functioning health systems without any, and they literally explicitly saying we're going to take out all that training, taking out all these other systems building things, rather than look at what the system strengthening was that was being done. If you don't think it was good, figure out how to improve it. But just removing it and making it a commodity transfer is a very short-run solution that completely flies in the face of the stated goal of helping the country build better resources. And so that's the missing part that is lacking in what they're currently doing. But in a sense, they're doing, as far as I can tell, what they can do, because they annihilated all the workforce that would have any ability to be more nuanced about how to spend money. So, big checks that go out to one government at a time is basically what they have the bandwidth for at this point, from what I've seen. But I don't think, my understanding is not much has happened there. And like these MOUs you refer to, I'm only aware of one that is actually public. So there's a lot of mysteries as to what is actually going to happen.
Yeah, so to follow up briefly on that, what I hear from your response is that these one area that was a problem is that we had these kind of parallel structures, and instead that capacity should be built within the local government, right?
Yeah.
But that's interesting because what it takes to invest in local capacity and institutional building is challenging, and also in the administration, when the administration announced this new policy, highlighted, they said that only 40% of health assistance previously was really reaching the front line. And from your experience in USAID, is that close to accurate? But also, like, how do you think about how much funding needs to be going into infrastructure to build out this capacity versus to that front line?
So I think the 40% number, I think, is more or less made up, in the sense that you can take any number you want for that, and I can show you an accounting way of coming up with that number, because how you define what people receive versus in kind is very nebulous. But a lot of that bean counting was about the first place that it goes to, not who receives the benefit. So like if you do cash transfers, the simplest thing possible, that's like the ultimate form of localization, is just handing someone money and letting them do what they want with it, right? So we're huge fans of doing this when appropriate, which is in a lot of cases. If you hand that money to Give Directly, which is the largest NGO in the world that I'm aware of that champions this particular approach, that would count 0% in the hands of people, even though 91 cents on the dollar is actually going to a household in cash for them to do whatever they want with. That's ultimately their money, right? And yet in the scorekeeping, that would count as 0%, when it should be 91%. So those numbers make whatever you want of them. It's a very difficult number to come up with to really get the essence of who's deciding what to do with the resource, which is ultimately what that's trying to ask. The broader answer to your question I think of is, the way, and this is true outside of health as well, the way I would often think about what we wanted to do, and if you ask me, like, what was our strategy for 2025, regardless of who won the election, it was recognizing that even though USAID was the largest bilateral in the world, we were tiny compared to local government. So if we can do things with our resources that influence how local government spends their money, and that's true whether it's Ministry of Agriculture, Health, Education, anything, that leverage has far higher returns than anything you can do with your own money as a direct service. So there's combinations you can do where you're using your resources, for instance, to pilot innovation and do things of that nature, pushing and helping the local government learn better ways of accomplishing the goals they're trying to accomplish. And so then you end up with a hybrid. But at no point in that process do you have to sit there and say, how much do we spend on direct services versus systems building? It's all one thing. It's one strategy that recognizes that with current services, you get leverage if you learn whether this is working or not. But you want the learning to take place from the keeper of the bigger budget, which is the local government, so that they fold in whatever works to their actual government operations. And that's the, when possible, I want to be clear, there's scenarios where you can't work with local government, you have to do other things. So this is not a cookie cutter, works everywhere kind of approach, but that's the philosophy that I think does make a lot of sense to try to get at the very tension you're pointing out, which is that struggle between direct services and system strengthening, and how do you balance those?
So that's useful. So Dean, you're talking about kind of how the U.S. can use its resources to leverage kind of change at the kind of technical level for better services. But I want to ask Shannon a little bit about kind of stepping back for the broader picture, because you've talked a lot about how U.S. global health leadership is in American interest already, right? And that this kind of framing of America First global health strategy is kind of bringing in American interests. Maybe we already were doing that. So could you talk a little bit to the audience about kind of, is the administration just saying the quiet part out loud? Is this what we've always been doing? Is there something fundamentally different about what we see in the strategy coming out of this administration?
Yeah, so ultimately the answer to the question is absolutely. Foreign aid is in the US interest. There's a big contingent of the foreign aid advocacy community that would like to think of foreign aid as sort of, we're doing this out of the goodness of our heart, which sure, we should absolutely pursue that, but I'm a touch more Machiavellian than that. In that, of course it's in the US interest. We're talking about soft power, and for the students in the room, I really hope you guys are reading Joe Nye. But it is a tool to develop our partnerships with implementing governments. It is a tool to make sure that the world is safer for impact on the US. Look, we all lived through COVID, and so we know better than we did pre-COVID, though the public health experts would have shouted this from the rooftops beforehand. Diseases don't care about borders, period. And so if we are addressing a disease somewhere else, it will ultimately help keep us safer and healthier at home. And that's the very basic answer. But at the end of the day, we're talking about what are the tangential benefits that we get from investing in global health aid that aren't directly related to health outcomes. And you see things like the impact of PEPFAR abroad. PEPFAR, the biggest global health program from the US perspective, just in terms of money standpoint, but also the biggest HIV program in the world. And that is what people know us for. If you travel to sub-Saharan Africa, where the HIV epidemic is so prevalent just in the cultural atmosphere, that's what they know about the United States. They know that the US has invested in this. And if you have the good chance to meet with some of the local communities, very likely you will meet a lot of little boys named George, because PEPFAR was created by George Bush. And it's a direct impact of they see the US positively through these programs. And at the end of the day, that's going to help build alliances, that's going to help build trade partnerships, that's going to have long-term impacts on things unrelated to health. The flip side of that is this is a big sea change. What's included in these MOUs, and I refer everyone to Emily Bass's Substack. She's published a number of the MOUs if you want to dive into them. What's included in that with regards to critical mineral access is a big change. We used to have global health contracts, we used to have global health programs, and they were more or less siloed in that regard. And so, yes, now we are saying the quiet part out loud of saying, we will give you global health in exchange for. And that's something we need to tread very carefully with, because to what extent are you using people living with HIV as a pawn for critical mineral investment when the purpose of the program is to get life-saving aid, treatment, prevention out into these needed communities, and saying, well, we'll only do that if we get literal money in return. So it is both a change and still in line with the past 20 years of global health.
Well, I have to very briefly insert a moderator note to mention that the Tobias Center is named the Tobias Center because it was funded through a generous donation from Randy and Deborah Tobias. And Randy Tobias, Ambassador Tobias, was the first PEPFAR administrator. So we have a deep connection to PEPFAR right here at IU. Ambassador Tobias is an alum. And PEPFAR alone is credited with saving at least 26 million lives. So that's impressive to think of the number of lives positively affected by that program. Okay, speaker note over. I have another question for you. Now that we're, it's really hard for the average person to keep track on what is actually happening with US government funding of global health these days, because there's appropriations, and then the appropriations are pulled back, and then there's litigation. So could you just, as a point of information for the group, where are we today? How much money is the US spending on global health right now?
Sadly, there is not a very clear answer to that question, because, as you said, there's a lot of different fingers in the pie. So you have, my background is congressional affairs. I worked in Congress. You have the congressional appropriations process, and God bless Article 1, Congress has the power of the purse, whether or not they choose to use it. And so they get to dictate what these appropriations go to. And right now, we've just wrapped up fiscal year 2026. That was all the shutdown chaos that we started the year with. And that bill, the foreign aid spending bill, is a bipartisan bill. The four corners, that is the chairs and ranking members of the foreign aid spending subcommittees, were personally, at the member level, very involved. And you had Republicans and Democrats working together to build out this foreign aid bill that included a significant investment in global health, because global health has been such a huge keystone of US foreign aid from the, essentially you can calculate the beginning of, or at least the modern era of health aid with the beginning of PEPFAR and the Global Fund in the early 2000s. And so that amount of money is just shy of $10 billion for an investment in global health. And with HIV specifically, you're looking at 4.63 billion for PEPFAR, 1.25 for the Global Fund, and the Global Fund has a whole match requirement that if you are interested in, come find me after, because I can spend too long on it, and $45 million for UNAIDS. That's sort of the three-legged stool of the HIV response. And then you have the flip side of the president's budget was released, 10 days ago, 2 weeks ago now, that takes that $10 billion budget and cuts it effectively in half, and says, thanks so much, Congress. We appreciate that you have appropriated this money for FY26. For FY27, we don't want that money. We don't want to spend that money. And so you end up with this push and pull between the administration and Congress, and it is not partisan. Again, I want to emphasize that. It is Republicans on the Hill and Republicans in the administration who disagree fundamentally on this. And so it is a little bit of Congress can appropriate, but they also have to conduct that oversight to ensure that the administration is spending and obligating and getting the money quite literally out the door to these programs that Congress wants to invest in. So it is that little bit of back and forth. And at the end of the day, we're still talking about cuts from the last couple of years. The 1.25 from the Global Fund does not equal the full 3-year pledge that even this administration made towards the Global Fund. And so what does that impact have on programs? As Dean said, they're looking to invest primarily in commodities. They're not talking about training or education or health system strengthening in the same way that USAID and PEPFAR previously used to. And so it's not just how much money we're investing in, but it is what programs we are investing in.
So not quite sure how much money we're spending on things, but we do know that one of the pillars of the America First foreign health strategy is disease surveillance. So Sabeha Sabs.
Just call me Sabs.
Yes.
It's easier.
So this strategy is narrowing U.S. focus to 4 diseases: HIV, TB, malaria, and polio. You've worked on the front lines of outbreak responses to Ebola and COVID, which are not part of those 4. And so could you talk us through what falls through the cracks when the strategy is built around addressing known threats rather than scanning the horizon for new ones?
And I was just talking about this earlier with Shannon, that I always have my drafted talking points and then I'm inspired in the moment, right? And and you're actually touching on something that's very important. So traditionally speaking, looking at HIV and AIDS, TB, malaria, polio, these are all critical diseases that should be focused on. However, at the same time, and I should also say just kudos to PEPFAR, because that was critical infrastructure across the world, across Africa, that essentially did its job in terms of COVID-19. That's part of the reasons that we didn't see the same level of cases of death and illness across certain areas across the world, because one, there was that PEPFAR infrastructure, right? We're talking about laboratory surveillance, the ability to actually also have a public that trusts healthcare, right? So you think about the idea that it wasn't just PEPFAR itself for HIV, but it was actually for all diseases as well. But then at the same time, what was so interesting is that we did not have the same level of, part of UNICEF, for example. I spent several years with UNICEF, and UNICEF has a communication, but behavioral change communication and communication for development division that works exactly in parallel and working with health immunization. It recognizes the fact that one of the key issues when it comes to diseases is not just surveillance, but it's trust, right? So when you look at diseases that aren't actually being accounted for, on one hand, we have an infrastructure for it. On the other hand, we're actually not looking closely enough at the diseases that matter. And that simply comes from political will, right? When it comes to local institutions and state actors or governments, you have to look at the fact that, and I think about my time with the World Health Organization, I was leading the Health Emergencies Hub in Eastern and Southern Africa for technically 17 countries, but it was more like 55, right? Because we have to support the entire continent at the end of the day. And what we see is that there are certain diseases that are predictable, like cholera, for example, right? That's directly tied to water and sanitation. And that means that there is actually something that government officials can do for their country to prevent the number of cases per year. What stands in the way, though, is actually political will and desire to address these issues. And that doesn't mean that they're doing something wrong, but that what we are saying, though, is that what is the barrier in terms of leverage, in terms of risk, that we're not addressing in our relationship with diseases and with disease surveillance? Because we have the systems, we can set up early warning systems. But right now more than ever, post COVID-19 and the pandemic, we are living in a siloed world of bilateralism, right? And nationalism, which is the two biggest hindrances to us actually doing our job in global health. So it doesn't so much come down to, are we missing the wrong diseases, but are we missing the collaboration, the trust, the systems, the political will to do the work that we need to do?
Yeah, so I was going to ask you a follow-up question about surveillance and sort of can we actually achieve the 7-day surveillance?
717,
yes,
unresolved state lives.
In the context of our current strategy, but maybe the better question to ask is like what do we need to be investing in on the trust front in order to make those surveillance systems work better?
Well, it's either they go hand in hand, right? So now at Pax Sapiens, where it's a small family foundation, and we're actually trying to address global catastrophes. So we're looking at nuclear risk, U.S.-China, global pandemic prevention, but we still believe in the 717 model, right? And ultimately, though, we are now stepping into a space where non-state actors, in terms of non-governmental organizations and foundations and local and state actors, have to step into this space where previously the federal government and multilateral entities were, right? And so when we look at the model for 717, it still is the standard. It's the standard that we're focusing on. The surveillance systems exist, but it comes down to interoperability between the different systems, between the different entities that are entering into bilateral agreements, between different countries, and then tied to that is trust, right? How do you convince multilateral organizations that are fundamentally also changing their own identity because of the current situation to trust in sharing information when they're losing money and relevance to some degree, or they're being challenged to some degree in this new world? How do you build trust with local entities and with national governments? How do you build trust with foundations that have had to step up into this space? And luckily, we do have new entities that want to step up, but we're also in a political environment where if you bring attention to yourself with some phrases, which we won't touch on today, you can find yourself in the crosshairs, right? And so I do think that when it comes down to trust, sometimes the best trust, and this is really funny because I was raised in a Muslim Christian family, but found myself at a church on Sunday because I just needed to feel inspired, I think. And I think, and this was at Red Rocks Amphitheater, which is the most interesting of sermons on Easter. But I really loved what the woman said, which is that, sometimes being small is more powerful. Sometimes being offline is more powerful because you're creating connections and relationships and an infrastructure and a system that's not dependent upon the noise and being seen. So you're not focusing on yourself, but you're focusing on the cause. And even right now, as I say this, one of the things that PAX is supporting is a health security operations center that's being stood up in the US for the World Cup. Because the US has stepped away from it as a government, we're working through foundations, 50 plus partners on local, state, foundations, private, Georgetown University, MedStar, we're collaborating to fill that space, to provide that surveillance for the protection of all World Cup sites in the United States and outside of. And that's a huge accomplishment, but it also inspires me that we can do it. But we have to do so in a way that is brutally evidence-based, right? While building trust in an environment that isn't currently as welcoming to global health. But at the end of the day, the work that we do is so critical, not just in terms of our sector, but to every single human being, that doesn't quite realize that COVID-19 could have been far worse. We were lucky in terms of the mortality rate. Because my last quote I would say is that when I was on the front lines in Sierra Leone for the Ebola outbreak, like that was the epicenter for Ebola. And when the outbreak started, we had a 50 to 70% mortality rate. That meant if you got it, you were flipping a coin or you were most likely to die, right? There were times that we were driving to our Ebola treatment centers and people died like in the taxi on the way there, right? And so on one hand, we had a very, a disease that was able to spread easily in lay terms, right? But in terms of being lucky, we were incredibly lucky because we didn't have the same mortality rate of Ebola.
Yeah. Well, I was about to thank you for providing a more optimistic outlook, and then you started to talk about Ebola, so I have to retract that.
Two sides of one coin. Two sides of one coin, yeah.
So for those keeping track, we've entered into round 2. So we're entering into shifting from what is the strategy to kind of implementation. And I want to hold Sabs on you for a little bit longer because I want to hear more about Ebola. No, I don't.
I even promised myself I'd be more optimistic today. And it's again, two sides of one coin.
Yeah, so you were talking about a model of global health implementation and service that is much smaller, and that there are some ways in which having kind of smaller, kind of cell-based ways of doing this is more resilient. But I am curious because in the conversations about what does it mean to basically obliterate USAID, right? Is that so? There's surveys that show that 71% of PEPFAR implementing partners have lost at least one entire service category. We have massive staff reductions, both among the kind of core of implementing partners, but also in country. Nearly half of clinics across 32 countries report substantial service disruptions. And so if the goal is to move towards that kind of smaller, resilient, kind of smaller scale model, like how much rebuilding needs to happen first?
Okay, so the chances of being optimistic. Okay. So I'm going to remove my current hat, which is, Vice President of Pax Sapiens, because before this, I've spent 19 years, with the U.S. or the UN, and 7 to 9 of those years was on the front lines in Syria, right, at the height of the Syrian civil war, on the front lines in Iraq, Democratic Republic of Congo, Sudan, South Sudan, Sierra Leone, and the list goes on, right?
Why do you always choose the easy locations?
I was just looking for a vacation, and and what happens as I work with this Mike that doesn't want to work with me, I returned from Nairobi, Kenya in last May, right? I was the regional head for Eastern Southern Africa, so based in Nairobi. And probably a year before that, I was trying to warn colleagues in WHO that we kind of saw the tea leaves. We saw there was a good chance that Trump was going to get reelected. And then because of that, I immediately was trying to talk to colleagues about what can we do to build resiliency immediately, considering that there was an asteroid heading towards us, right? Because essentially we lost, $1 billion over 2 years, right? And when that asteroid hit, right, my staff, I had 70 staff. And so some background, when you understand, if you're working in a war zone, you have just your staff. But if you're based in Nairobi, Kenya, it's not just the staff, but also their families are posted there as well. And that's the case for the 5,000 expats that are based in Nairobi, Kenya. And I become emotional, I always do, because when that funding cut at USAID, and I'm former USAID as well, when that funding was cut for WHO and USAID, it wasn't just, and we'll get to the actual impact for individuals and the local population that we serve, but the workforce itself was already exhausted post-COVID, right? So think about like every hospital in the United States, how exhausted frontline workers were. This is the same people that have been working on the front lines for probably 10, 15, 5, 20 years. Then COVID-19 happened. Then they kept working, right? So they're dealing with exhaustion that's just unimaginable. And then after that, they also had the funding cut. And I remember hugging a colleague from USAID because his children were so heartbroken about losing their best friends because they had to immediately leave and go back to the United States. And they didn't even know where they were going to live, right? We started creating WhatsApp groups to open up spaces for people to open up their homes back in the US, to have places to live. And then you have individuals at WHO and the UN just not knowing if they're going to lose their jobs. And that degree of fear after such loyalty for years is heartbreaking. And then you get to the actual impact on the ground. And we'll get to the good part, hopefully, sometime soon in terms of inspiration. But then we have all the services that were cut, right? So we're talking from HIV and AIDS and tuberculosis, but health emergencies in terms of cholera, in terms of Marburg, in terms of health system strengthening, in terms of data analysis, all of this was actually on the chopping block. Now, one of the things we have seen inspirationally is, again, actually seeing other, like on one case, for example, we see institutions like foundations stepping into the space and trying to determine where they can provide value add, right? We see institutions that are thinking about, well, how do we create bilateral agreements from Europe, for example, with local countries across Africa and the Middle East to actually address these areas. But ultimately, it's heartbreaking because you know that no matter what we're trying to rebuild, there has been irreparable damage that's been done that will take a long time to recover. I am optimistic, though, because there is this conversation around, well, how do you create these new systems? And then also, how do we change our funding model so countries aren't dependent upon aid, right? And that's always been the question. How do you convince government leaders of their nations to invest more in their people? How do you create, like Africa right now is having the discussion, and I don't see this as like one unified continent, but several countries are talking about, well, how do you create a stronger economy and look in terms of like investment? And so that way they don't have to be dependent upon other nations. These are great conversations that should happen, but as I was chatting with Shannon about this earlier, is at the end of the day, the right questions are being asked. There were consequences or considerations around how USAID was functioning or how WHO was functioning. But the answers that have come in the last year and a half, I'm not going to mention this administration, is the answers is wrong, right? Because we go from 0.5% corruption to a situation where, we've removed an entire leg from a sector, from a country, or from a continent, from an infrastructure that was functionally working. So I am optimistic that there are people who want to step into this space. I am a true believer that there is a comeback for global health, there's a comeback for surveillance, and then we can actually remodel into a better structure. But it's going to take also the American people truly understanding the importance of global health, the importance of aid, and that there are no borders. Because health here at home is directly affected by health in any country worldwide.
So that was a really eloquent response about kind of starting from the micro to thinking a little bit of the macro. And Dean, I want to turn to you because your career is really about evidence for action, and you have a unique kind of vantage point as someone who has spent a lot of time at kind of looking at that micro level for evidence, but then having the bird's eye view as the chief economist at USAID, perhaps the last chief economist of USAID. We'll see. Hope springs eternal. So could you talk a little bit more about the kind of what is the pathway towards achieving this goal that's baked into America First global health strategy, that partner countries need to be self-reliant in 5 years, especially given, what Sabs was saying about how we're starting from a deficit, right? So we're not starting from a crouched position. We're starting from the ground.
So, for what it's worth, I would not support the goal for a very simple reason. I have no problem saying I support the goal. So I'm not sure if this is going on the internet in this way, but like, there's a certain it allows one to focus. It allows one to focus on strengthening government. So there can be some good byproducts of saying that's your goal. But in my mind, I can't help but imagine the world 10 years later. Imagine we're amazingly successful in all of our aid programs. Yet there's still going to be, the poorest country in the world is probably still going to be the poorest country in the world. It's certainly going to be in the bottom 10. We're going to see the world get better. The world gets better over time regardless of whether we do aid. Overall, in the long arc, poverty does go down in the long arc of history. So that's going to continue. We're going to get wealthier and wealthier, though. And our perception of what's bad and what's tragic and what brings out the humanity in us to want to do something about that will still be there, regardless of whether the poorest country in the world is the poorest but a bit better than they were before. So I don't see a world where in 10 years we look at the tragedies of the world and we say, we no longer care about that because we think you have enough money to kind of handle some of that yourself. So that's where I'm not a fan of putting that forward as a goal unless I want to be Machiavellian about it and just say, well, fine, if that's your goal, that's okay because no one's actually going to hold you accountable in 10 years to that. So I'm going to play ball and claim that's my goal too. Because it does actually focus you on strengthening government, which is important. That if you can do that, that is going to improve things in general. Like you can do it well, you can do it badly. So it's not to say it's like a simple concept, just strengthen government. But that is, that's why I'm always a little torn when that topic comes up, whether to keep my mouth shut about what I really think will happen or not. The one other thing on that I would say is that, and it's a little bit of the challenge with soft power, going back to what you were saying too, which is there's an empirical challenge with it. The way you describe the work I've been doing, and prior to being at USAID, as kind of micro, setting up projects to understand, does this program work here, right? Is a direct response to the challenge of, the prior question that would get asked is, does aid work? Right? And we would always say, that's just such a bad question. I can't answer that question. The answer is, does this program, does this policy work here in this context? What can we learn about the context in this program that we can extrapolate to others? But asking, does aid work? It's like asking, the answer is obviously going to be, it depends. And so similarly, when you look at the country level macro outcomes, like if you look at GDP and unemployment, and there were conversations I would have in that where people would track that in the country and they'd be like, what's their unemployment rate? We're going to try to get that down. And unemployment rate went down. And we had some programs that did job training, so we're going to claim credit for that. And I was just like, you're a drop in the bucket compared to the country's GDP. You're not moving the needle on that in a way that you're observing. And that's going to just move because it moved. It's going to go up. It's going to go down. And if it, pointing cases, I remember having a conversation specifically with a country that was spending millions of dollars to track some things like that. And I said, so when things get better, you're going to claim success? They said, yeah. And I said, when things get worse because of a drought or whatever, are you going to say, oops, sorry? You're like, no, we're going to go double. In what sense is that telling you anything? And this is this last thing I was going to say, is this is what I see as the fragility of the soft power argument. And I agree with what you're saying, don't get me wrong, but there's a fragility with soft power. The problem is you don't have a linkage from, in most cases, you don't have a link from a specific program to a specific soft power benefit. Mm-hmm. It's more diffuse. You might do 10 things. One of them might lead to something that generates that soft power, the other 9 not, let's say. So if you went and evaluated the impact of the 10 things on, quote, soft power, you'd say 90% failure rate. Right? But that's not fair, that's not right. You need to think of it as a portfolio and that aggregate impact, but now you're back to this asking this empirical question of, does aid work on strengthening the US's influence in the globe? That's a very difficult thing to answer, and the reality is, this is where we enter into evidence-based policy making is the goal, and we end up with the other, which is policy-based evidence making. Okay, the point is, you want to make an argument that soft power is not right and it's not really there. There's ways of looking at the data that would say that, and there's ways of looking at the data that say it's there. And the reality is, the answer is it depends, and so you can get what you want out of that. And that makes it fragile. And so even though we see Republicans and Democrats, like you're saying, in bipartisan support arguing for soft power, it's still a weak argument in terms of its fragility. I think another argument, which I also like and actually prefer, although I openly recognize I could be wrong about what's the better argument to make from influencing policy, is that when you look at public opinion polls, Americans, just like most nations, people who are rich, want to do good. They want to live by the golden rule. They want to help others. A government should represent its people and then act on their behalf. Full stop. Nothing more needed. That also, you could argue is fragile. So I admit that that might be weak too, in terms of its ability to be weak in terms of being the underpinning to justify foreign aid. It certainly doesn't give you any boundaries on how much to spend, but it doesn't have an empirical weakness in quite the same way. I don't know which is more effective for influencing Congress, presidency, and things like this, but I see both as strong arguments and with fragility that can be manipulated as the politician wants to make their case.
All right, well, the economist is talking about measurement, so all is right in the world. You also scooped my question about kind of how we would evaluate the effectiveness of America First foreign health strategy, given that it has different goals than what we normally think of when we think of global health. But that's good because we're running close to time. So I want to ask Shannon a question, and then we're going to throw it to you all to ask questions. So start thinking and be ready to quickly raise your hand. So this is my question for round 3. So Shannon, you get the first stab at it. So you were mentioning before how Congress has allocated $9.4 billion for global health in fiscal year 2026. We don't really know kind of whether that's going to be spent or not. And could you talk a little bit more about what the congressional dynamic tells us about whether the kind of pullback or the change in the approach to U.S. global health strategy is reversible or not? Do we think that there is a chance to return to what we had before in a future administration, or do you think instead we should be thinking about what comes next rather than restoring something that has been lost or has been discarded, depending on the words you want to use there?
Yeah, very quickly, just to carry on what Dean was saying on metrics. The MOUs have these built-in metrics that, to be honest, we don't know how this is going to work. And so I want to encourage everyone. My colleagues at AmFAR put out a report, I think yesterday, evaluating the metrics in the MOUs that we can see so far, and what is really missing from what are the metrics that we're tracking and what is the data transparency need. So I wanted to flag that report at least. And then to your question, Sarah, I don't know that we want to go back to where we were 2 years ago. I don't think there were really all that many people who said USAID is perfect, nothing needs to change. Frankly, an agency that big, there are always going to be issues that need to be addressed. And so this is, what Sabs mentioned earlier and what she and I had discussed earlier is that you need to both ask the right question and get the right answer. And so asking the question of what does the next era of foreign aid look like is absolutely the right question. But going back to what we had before is frankly just not feasible. because we've lost a lot of inherent trust with implementing countries. We've lost a lot of capacity with NGOs and implementing organizations having to pull back, lay off staff. And what the infrastructure, frankly, of global health is not going to go back to what it was in 2023. It's not going to go back to what it was in 2019, pre-COVID. And so we need to be thinking critically about, okay, what comes next? And, it has to be, Congress has often appropriated and still does in its ultimate structure of foreign aid, line items, right? Where it says HIV is going to get X amount of dollars and TB is going to get X amount of dollars and maternal and child health and so on and so forth. And that's great. And those line items need to stay. And we need to think more holistically about health system strengthening, about where there is overlap between disease surveillance and treatment. One of the things I talk about frequently when I'm talking with members of Congress and their staff is that it's easy enough to think about HIV and the drugs involved and the prevention involved and the testing. But ultimately, the thing that most HIV positive patients die from across the world is tuberculosis. And tuberculosis is, kills more people than any other infectious disease in the world. And it's not just TB, it's multi-drug resistant TB. It's, when we're talking about mortality rates and transmission rates, like TB is what keeps me up at night. I work on HIV and TB is what keeps me up. And so these things they can't be addressed in silos. So, when we're talking about the bare money of it all, I would love to see more investment in global health. Absolutely. I would love to see us get back to those numbers that we were talking about 3 years ago, 5 years ago, et cetera. I'd love to see maximum investment in the Global Fund, in PEPFAR, in UNAIDS. And at the same time, we need to be thinking about what lessons were learned and also what can we be shifting towards. Ultimately, global health is no one's top priority, in politics at least. It's not going to be what swings an election. It's not going to be a member of Congress going out and saying, I championed all this money for PEPFAR and it's going to get them votes. The goal that we have is to make it hopefully somewhere in their top 10 or something they can support, maybe not as publicly as we would like, but behind the scenes and vote for the appropriations bills that has increased funding and things like that. And at the end of the day, I think what we sort of in the broader advocacy community are asking for is that it's not just the number involved, it's asking members of Congress, it is asking their constituents, it is asking the broader public in global health to care, to realize that this is an issue that operates very much under the surface, but impacts so much of what we do. We talk about the malaria programs that we have. One, that if you go all the way back, it's based on, actual malaria in the United States, in the southeastern. But the malaria programs we have now are based largely out of Walter Reed because it impacts our troops. Because, first in, first out, when we're talking about military security, they're impacted by disease. It's not just out of the goodness of our hearts. It is very self-interested. And so how do we sort of make all of those things work together? What does that look like going forward? I think is going to be the big question in the next era of global health.
All right, well, that's a great place to start asking for questions. So who would like to go first? Okay, I see a question over here, and then you're going to be next.
First, thank you. It was very refreshing to hear about these topics from professionals.
Could you please introduce yourself?
Oh, my name is Mia. I'm a sophomore. I'm also at Hamilton Luger Student Government. So my question for you all is, right now a lot of the dialogue against global health is the fact that a lot of Americans have lack of access to health care. And there's this dialogue of, well, what about us? Why doesn't that money go to us? So as young, globally minded students, how can we answer the question of how does investing in global health in turn invest in the advancement of health and quality of life for people in the US as well?
Sure, great question.
Yeah, so first, some basic numbers, right? The foreign aid budget, all foreign aid, is less than 1% of the US budget. And within that, global health is, again, a drop in the bucket. So we're talking less than 1% of all of our expenditure. You flip that into domestic health spending, and I don't know those numbers off the top of my head, but it's trillions of dollars. It's just not comparable. That being said, it absolutely is the right question for American constituents to be asking. Why do we care about what's happening overseas versus what's happening here? And again, in my sort of like most basic Machiavellian interest, the innovation that we have for diseases overseas absolutely makes us healthier here. So the new shiny object in HIV is this shot you can get every 6 months, twice a year. It's called lenacapavir. It is produced by an American company, Gilead. And it is 97% effective at preventing new HIV infections. HIV doesn't have a vaccine, it doesn't have a cure. This is the closest we've gotten. And that drug is also available in the United States. And it is very expensive in the United States. The HIV epidemic in the US is an entirely different topic of conversation. Again, find me after. But that sort of innovation, Gilead is going to make more of its money abroad than it's going to make in the US, but it is still going to have a concerted impact for the health and safety of Americans. And frankly, just the impact on our economy of having a private sector pharmaceutical doing well and having, building out more jobs and the creation of private sector investment. But yeah, we have to think about it, frankly, as like, we all lived through COVID. If we don't stop a disease there, it will hurt us here. Any other?
So kind of building off of what Shannon said around, it is a drop in the bucket, right? In terms of it's $1 billion, right? Then you look at, also look at the rest of the federal budget, just for a moment, right? There's about, 70 billion, 80 billion going to ICE right now. There's trillions of dollars in terms of military. That doesn't mean, I'm not going to get into the politics of it, but if you look at just how we spend our money, right? 1 billion for USAID or for foreign aid is nothing, right? Secondly, when it comes to global health, right? One of the weakest systems we do know in terms, at WHO, I learned this when I was there, they referred to the US health system as the wild, wild west. Because if you walk into any hospital in London or Nairobi, Kenya, right, you're going to be taken care of, you're going to get the same quality health care, but for a lot less, right? And that's something that, again, it's not about the money, it's about the political will and the decision makers, right? So yes, we need to address, and I say this with empathy, we have to address the weak healthcare system in the United States, right? But if you look at investment, public health, prevention, right? So that's what I focus on. Prevention and interventions upstream don't just save lives, but it saves money, right? And so it shouldn't be an either or, it should be both. Right? We should be investing in both. And if the argument was that we cut foreign aid to invest in domestic health, right? That's not what's happening, and that's not what we're seeing, right? So actually it should be investing in both. And then lastly, in terms of epidemiology, going back to that disease does not have borders. We saw this again, right? Anyone can get on a plane, right? And land in a different city, and disease spreads. It's not about closing borders, it's just increasing surveillance mechanisms. That 717 approach, right, to addressing it, we have to strengthen that everywhere. So it's not taking a step back, it's taking a step or 5 steps in and strengthening healthcare systems globally as well as in the United States.
Did you want to say? Yeah.
So, let's say 3 brief things. One is, just reiterates some points, but just points out that there is a movement from if one thing is slashed in the federal budget, it doesn't just, no one sits there and says, where exactly are we going to put it? So really, the better way of thinking about it is it's future money. It's deficit. That's really where it's, so if we don't spend it, it goes back to the federal government, and the deficit less, that means your kids and your grandkids have less debt to repay. That's it. Right? And so then it's not a matter of thinking about, it's not to say there isn't some trade-off there, but you just have to think about whether there's a return on that from a societal perspective or not. And don't think about it as this versus that, because then we end up down this, it's never ending if you literally lined up everything the US government does and think that you're optimizing. So the second point is that I doubt that we want to be at a corner solution where it's zero. I mean, maybe some would argue that, but then I go back to the point that I was making on what is the will of the people. The will of the people is not to be at zero. In fact, the will of the people, there's public opinion polls that show most people think that on average that we spend 25% of our money on foreign aid. Right? You heard the number.
Would that it were true.
You heard the number. They
Gosh,
think we
wow.
should spend only 10% in this public opinion poll, to which my answer is always fine. You win, right? But you heard the numbers, right? The last, I do have one fear. I'm very sympathetic to the arguments you're making, don't get me wrong. And I've used them myself. I do have a fear, though, which is if we take the focus to be strictly on the infectious disease story, we then risk that becomes the definition of what we're going to do on foreign aid. And yet, if you're in Ghana or you're in Malawi and you're dealing with health issues, not all of them are issues that are about an infectious disease that could get back to the U.S. And do we really want a system that has that as a top-level filter? And that makes me very scared, right? And so that's where I go back to a different answer to your question entirely, which is to say, on a personal level, I don't care what passport you carry. What's the cost per life saved?
Yeah.
And the answer is radically cheaper. So then it sounds a little bit different than everything else I've said, I realize, but that's call that a philanthropic way of thinking about the world in a kind of an effective altruist kind of spirit of just like, where do we get the most bang for our buck? If all you care about is saving lives, where is it going to be cheapest? And the answer is where people are poorer, it's much cheaper to save lives.
Yeah.
We invited Dean and we got Peter Singer. So we have, I'm going to take your question right here, and then there's a question in the back, and then we'll, so we're going to take two questions.
First of all, thank you all for sharing your knowledge with us. I'm Kelly Branson. I'm a senior here at HLS. So I'm studying international studies with minors in sociology and Southeast Asian studies. My question is kind of a little bit off what you have all been discussing. So we've been discussing a lot of infectious diseases and a lot of physical health, but I'm asking more on a broader health perspective. What can we do as a community, as a country, in different organizations to address broader global health issues such as mental health or physical safety and things like that, especially in areas that might not recognize those as health concerns?
Okay, great. Global health outside of infectious disease. And then I saw a hand in the back, and we'll have you ask your question, then we'll throw it back to the panel.
I have. Sorry.
Here,
It's fine.
Mia has it for you. Yep.
Thank you so much. Okay. Hi, I'm Lucy. I'm a freshman studying international relations and international law. So I was sort of wondering, so my family is very my dad is a statistician and he doesn't believe that COVID had strong implications on how the U.S. views health. I think it does. How do you think that COVID has changed how the U.S. values foreign aid? Because I think that a lot of people have started to think that since COVID was so bad, we over-dramatized it. It was such a decline. And you even said that we need to talk about getting communities interested in it. So for one, how do you think it changed? And then two, how do you think you can advertise to local communities that it's important?
Okay, we got to help Lucy win the argument with her dad. So, all right, so two important questions. Throw it out to all of you. Who wants to start?
Who wants to start?
Sure. Okay, so question one on non-infectious diseases. Mental health is a really difficult topic within foreign aid right now because it's hard enough to get invested in diseases where you're seeing the quite literal physical manifestations of it. And then you have NCDs, non-communicable diseases, which are becoming increasingly causes of death in low and middle income countries. And at the end of the day, it's about investing in health systems. Because if you're a mother in Nairobi and your kid is sick, has got a fever or whatever's going on, and you bring your kid to a health clinic, you do not care what the answer is. You care about how does your kid get better. And that's where it really becomes about talking about health systems as a whole. And you can get into the granular data of like how much we're investing in education around these topics, how much the individual diseases have impacts on one another. But at the end of the day, it's about treating humans holistically because we are. And so I don't have a great answer for you on mental health, except that we should absolutely be talking about it more. On arguments with your dad. One, I'm 90% sure my dad is watching, so hey, Dad. But at the end of the day, the argument is not COVID was worse than, or was better than everyone said it was going to be. It's that it could have been so much worse. It could have been so much worse. And I realize that like we do not have the institutional or human memory to look back at 1918 and the Spanish flu, but that decimated the world population in a way that we do not have the modern ability to calculate. That how it would impact our culture is just wildly out of proportion. And so we have all these systems that prevented COVID from being the Spanish flu. I always feel bad for Spain because it did not actually start in Spain. Again, ask me things
Horrible
later.
PR.
But at the end of the day, how we convince people that global health matters is ultimately, yeah, COVID could have been a lot worse, and there will always be a next pandemic. There will always be a next disease. Will it be something we already know about? Will it be a cholera outbreak? Will it be Ebola or multi-drug resistant TB? Or will it be a thing that, somewhere there's an epidemiologist working on this, but that I can't even begin to fathom of what that disease would look like? Because if we don't invest in it now, we will absolutely be paying the price in the future.
100%. I guess I'll go next because I'm just shaking my head in solidarity.
We clearly aligned beforehand.
Yes, yeah. Mental health first, right? Partial, 100% in agreement, but then also building off of it. One of the articles I actually wrote for CFR and Think Global Health had to do with workforce burnout and safety, right? And that comes down to, for all healthcare, coming down to healthcare systems, it comes down to infrastructure. Healthcare workers there's not enough of them. They're not being supported the way they need to, right? And it's mental health stability of the healthcare workers, and it's also mental health stability of everyday citizens, right? And when it comes to a strong system, it's that primary care level, right, where you show up. That primary care physician is the person you go to for every single disease, and then they move you forward to where you can get treatment or how to get treatment, right? So the healthcare infrastructure is, at the end of the day, intertwined, and the vital section of that infrastructure, I think, really comes down to healthcare workers, right? And we have this thing after pandemics that's called pandemic amnesia. The people want to move forward and forget and start living their lives. And because of that, then we also don't invest in the system for all diseases the way we need to. Prevention is incredibly upstream, right? And if we do that work, if we remember, then we can prevent and be more resilient when the next disease outbreak happens, right? And that comes down to infectious diseases. That also comes down to mental health and mental health capacity, right? If we ignore the fact that we're experiencing mental health trauma or amnesia from everyday stresses, right? I've never heard from so many people as they process what's happening in terms of foreign policy, in terms of Iran, in terms of education, in terms of everything. We can't just ignore it, right? We have to address it and we have to support it, and that comes down to creating that system. One last comment though on the mom answer for your dad or dad answer. For another day, find me later. But public health was blamed for a lot that ultimately were leadership decisions outside of public health, right? So evaluate that the way you want, but find me after.
Okay.
Sure.
Yeah.
So, I think mental health is an interesting area because there's paths of delivering mental health treatments that are actually outside the health system. And so I think that's an area where there might be answers that are actually more easily scaled than other things, than the physical health space. AI for mental health is actually, quite with chatbots that can walk people through and things like this. And so we're seeing a lot of efforts there. I'm personally involved in, for instance, an AI chatbot for LGBTQ youth in Africa, where they don't want to go to a health clinic because of the stigma and the threats of death and things of this nature. They love the idea that they can talk to an app that they know is not a human. So it's usually you want the chatbots to pretend to be human. This is one where you actually don't want to pretend to be human to make it work. So we're testing it. The biggest thing I would say, though, is we don't have great evidence of what works and what doesn't, particularly in this context for the people. What we do see is consistent evidence and more or less consistent evidence of links from mental health to other types of outcomes about like income generating activity and making more money. And so there's actually an appeal to make outside the health system. You make it to the Minister of Finance that you can collect more tax revenue if you have a healthier mental health workforce, because people are then more, they work more when you're happier or less depressed. So there's links there that are outside of our normal channel, and there's, I think, growing energy in that space that's very exciting, but definitely needs like evidence at the small scale.
All right, they knew this was coming. You each have 30 seconds to tell us what is the one thing that you want the audience to take away from this discussion on global health strategy. All right, we're going to start with Shannon because you spoke last.
Care, honestly, just to care about global health. And extrapolate that forward. Convince your dad to care about global health. Convince your member of Congress to care about global health. Convince your fellow students. This is an issue that will always be, like, health is not going anywhere. Even if we were to cure all the diseases tomorrow, there will be new ones. There will be non-communicable diseases. We didn't even touch on sort of cancer development and heart disease in low and middle income countries. There will always be something coming next. And so the most important thing I can leave you with is just to pay at least a little bit of attention to what's happening in the health world, because it will impact everything else. It will impact stability. It will impact job creation. It will impact, what everyone can do. I can see Sarah looking at me because I've gone over, but just,
30 seconds, woman, 30 seconds.
All right, Sabs, go ahead, and then we'll end with Dean.
We'll make it quick. Prevention, right? I don't know how long we've been saying this for decades. Prevention is key, right? Political will. And then I think at the end of the day, we say all politics is local, all healthcare is local too, right? So that's it.
All right, thank you. Dean.
I would say we have to work to strengthen local government and help them learn and help them build knowledge for what's working for them. We will benefit from that, just as you were saying. And that the flip side of that is going to this transactional approach that you described. We're going to give you aid, and I'm going to put that in air quotes to make this point, in exchange for mineral rights. That's not aid anymore. That's just selling life for their future money. That's all that is. That's taking their future revenue and saying, we're going to extract that from you at a really good price for our oligopolists. And in exchange for that, we're going to give you life-saving medicine. That's just no longer foreign aid. When USAID was first collapsing, I was in a conversation with a Republican about how do you measure and this kind of transactional approach, right? And how do you measure what makes America stronger? And they were kind of an advocate of this more transactional approach rather than the relationship approach of strengthening government. And the conversation ended, and we said, okay, we got to have another phone call. We've got to discuss this more. I said, how's Tuesday? He said, great, let's do Tuesday evening, that's fine. And he said, oh, wait, I can't. It's my wife's birthday. And I said, oh, why? Do you have a contract on that?
Oh.
And he's like, no. And I was like, well, then I don't understand. Why can't we do it? So the point is, it was a relationship. Not everything gets contracted, detailed out, quid pro quo. That's a healthy relationship. And that's the approach we need to take with the country partners.
Yeah.
All right. Well, with that, I want to thank our panelists for an excellent discussion and audience for excellent questions.